My name is Marv Feldman. I'm the Shine Counselor here at the Walpole Senior Center. I'm a volunteer, and we use Tuesdays for the office days when we have Shine meetings with people if they'd like to come. Bob Mora also works with me, and he also works over at the Milton Senior Center. So, you know, there's Shine Counselors almost in every town, every city. But we're all trained, certified, and we're all volunteers as well. And that's important because if you look at what Shine Counselors do, they're helping you look at how do you sign up for Medicare. If you're already on Medicare, how do you make sure that the programs that you've got and the coverage you got is optimal for you, that you don't have more insurance and pay more than you need, but by the same token, you don't want to find out down the road that, wow, I should have had that plan instead because I'm not covered because I didn't know that. So what's really important in Medicare is getting unbiased information, knowing how to get in on time, because there are penalties that stay with you for life if you don't sign up, if you don't do certain things in Medicare. It's a pretty stringent program. And not knowing what you were supposed to do or when is absolutely no excuse in the eyes of Medicare for having not done it. Some of the other things to be aware of, when you talk with Shine Counselors, as I said, we're all volunteers. So there's a lot of people as you get into Medicare and while you're on Medicare, they're going to approach you and tell you about this insurance plan and that insurance plan and so forth. What you really want to know about is, are they paid? Are they commissioned salespeople? And if you look at some of the ads they show you, at the bottom you'll see somewhere that it says commissioned salesperson. So what's that mean? That means nothing more than they are sometimes almost like used car salesmen. They're trying to direct you to sign up for certain insurance plans that they're getting a commission to sell you. That doesn't mean they're working in your best interest. Now, I'm not going to say they're dishonest. I'm just saying they may not be incentivized to be working in your best interest. But when you talk to a Shine Counselor, because none of us have any financial gain in any of this, we're simply here to instruct, to educate, to help guide you and so forth. That's all we do. You can be pretty sure that a Shine Counselor is not going to put you in the wrong direction. They're going to understand what your needs are and kind of outline the things that will make most sense for you, okay? So keep that in mind. The last thing that we typically do is screen people for public assistance. So there's two big things to be aware of. There's Medicare, which is what people sign up for when they're 65 and so forth. But there's Medicaid, or in Massachusetts we call it Mass Health, which is the public assistance program. So somebody could be on Medicare and also be on Mass Health, which means it helps them with some of the premiums and so forth and the deductibles that we pay as we're under Medicare, but Mass Health helps them. And usually the people that qualify, it's because their income or their assets or both are below certain levels that qualify them for public assistance. So as a Shine Counselor, we help screen people to see, well, we're getting to help you on your Medicare, but you should know that based on your income and or your assets, you might also be able to access public assistance from the state or federal government. Okay, so when you enroll in Medicare, there's a number of different time periods that you can do this. Okay, now as I said, there's a lot of scheduling to all this. So when you're turning 65, and that's the operative time when people usually start signing up for Medicare, just to get started with everything, they've got a 7-month window within which they can sign up. It's usually, or it is, the 3 months prior to the month in which you turn 65. So if you turn 65 in January, then it's December, November, and October. You could start signing up for your Medicare. It's the month that you turn 65, and it's the 3 months after you turn 65. So it's important to know that you sign up within those 7 months, because if you don't, and if you're not covered by something else, like an employer health insurance plan or your spouse's insurance plan, when you eventually do, when you go outside that window, that's when they start tagging you with lifelong penalties. And they're going to take the premiums you pay and increase them by the surcharge, and that will stay with you for the rest of your life. So it's important to be aware of this initial enrollment period. So what happens if you miss that? You still got to sign up, but the government says, well, just because you missed it doesn't mean, okay, we'll come down today and sign you up. No, you have to wait till the general enrollment period. And that's every year from January to March 31st. So, find out my birthday's in August, I didn't sign up within the reasonable window, now we're looking at November, I can't do anything until the general enrollment period and start. So now you got months, and think about it, if you didn't have coverage and you can't start till here, you got months of potentially no coverage. And I think we all realize in this day and age, you just can't go without insurance coverage in the healthcare world. There's an open enrollment period, and that runs in October 15th to December 7th every year. So what happens then? This is the one time every year that you can change anything you want to change. So if you signed up for a Medigap insurance plan, you decide you don't want to be in that, you want to join an Advantage plan, and we'll explain how these are different. And there's reasons why certain people sign up for one and other people might sign up for another one. And you decide it's not working best for you. Well, you can do this change between October and December. You can change the plan, you can add it, you can delete it, you can move to something else, you can change your prescription plan. Anything that's just not working for you, you can change it during open enrollment, and those changes will become effective January 1. But this is a really important window to be aware of. If there's anything that hasn't been working for you with whatever Medicare plan you've got or whatever supplemental plan you have, make sure that come open enrollment, you've done your homework and your research and you're prepared to make those changes, because that timeline goes pretty quick, and then it's going to start for you in January. And the other reason when people have the ability to sign up or make changes, there's a list of what they call special enrollment periods. Like if you relocate, you move from Massachusetts to New Hampshire. Well, that doesn't mean you have to stay with everything you have. That change, that life-changing event you just had, moving, may entitle you to changing your insurance plans or changing the supplemental plan you have or your prescription plan. So once again, you're moving, say, from Massachusetts to New Hampshire. You want to seek out the Shine counselor or what they call SHIP counselors in other parts of the country and have them help you just as we would have done here in Walpole. So a number of different enrollment periods. It's important to be aware of them: initial, general, open, and special, because each one of them has a different purpose. So just to give you an idea of some of these lifetime penalties that you can incur if you miss one of these deadlines or if you do something wrong. That's why it's really important to check with the Shine counselor and find out, well, when am I exactly supposed to do this? I'm leaving my job, I'm leaving my health insurance plan. How quick do I have to sign up for something else? Or my wife has a plan, I've been under her plan, but she's retiring in 2 months. When do I have to do what I have to do? So check on those things, because you can see the penalty is 10% of the premium. The current premium, Part B, is $185. So on a monthly basis, by missing this and being penalized, your premium goes up by $18.50. Do the math, that's a lot of money. And it adds up, and it isn't like it's going to go away after you've paid a certain amount. It isn't going to go away after the first year. It's going to stay with you for the rest of your life, or as long as you're under Medicare. The prescription plan also has a penalty associated with it. So this is something that sometimes people will come and see us and say to us, I signed up for Medicare. I didn't sign up for a prescription plan 4 years ago when I signed up for Medicare because I didn't take any meds. I figured, I don't take meds. Why do I need a prescription plan? The government doesn't care. They don't care whether you take meds or not. They want to make sure that you've got Part D prescription insurance. And if you don't, and then you start, and this is what happens, someone will say, I didn't sign up for 4 years, but all of a sudden the doctor started prescribing medications for me. Now I'm getting prescriptions filled, but I don't have a prescription Medicare plan. Well, what's the deal? Well, you're going to have to sign up for a plan, but now you're going to pay 1% of the current national base, which is about $30 a month. 1% of $30 a month times the number of months that you did not have that plan. So if that person for 4 years, that's 48 times 1% of $30. You do the math. If the premium on the plan was only about $20, you're spending way more for the penalty than you are for the premium. It's expensive. You want to make sure you don't get hung up by any of these late enrollment penalties. And once again, it's a simple process. Just ask the Shine counselor. If you're not in Walpole, If you're in Norwood, go ask the Norwood folks at the Senior Center. I mean, if you're Milton, go ask Bob. You know, they're gonna help and make sure that you're in the right place. Okay, now, at this point, when we have groups like this, I usually ask, and what we've learned is people fall into two buckets. I don't mean literally, I mean they just catalog into two buckets. Some people in the group are new to Medicare. They're turning 65 shortly. And so they're really interested to know, when I hit 65, what am I supposed to do about this? I hear a lot of people talking about Medicare, but I'm not exactly sure what to do. And you know, all my career, it was the Human Resources Department at my company that used to tell me what I had to do. Now, I'm not gonna be there anymore. Perhaps I'm retiring because I'm 65, I'm going to leave. I don't have them to help me anymore. So generally, this first group of people that are turning 65 soon, they want to understand how Medicare works. They want to know, what do they have to do about enrolling? Do they have to enroll in this Part A? And we'll talk about what that is. Or do they have to enroll in Part B, or both, or one, or the other, or what? I mean, it's very confusing. And they may or may not even want to do something, because even though they're hitting 65, they're intent to work till they're 70. So they're not leaving their employment. They still have their employer health plan. But what do they do with that and the fact that they're turning 65? What's the government require them to do? That's usually this group. And anybody here fall into that category? A couple of you, okay. The other group are people that are maybe leaving their employer health coverage, okay? They're beyond 65. They previously enrolled in Medicare Part A, but they didn't take Part B. They took hospital, but not medical. And now they're, and they want to know how to enroll now in the medical coverage that they said they weren't going to take because they were covered by an employer's health plan. Anyone in that bucket? Okay. And then the third is people that have been on Medicare, have to take everything, already signed up, already enrolled, but it's been a few years. And they want to kind of do a checkup. They want to make sure what they've got is the right plans for them to be in. They want to go back and ensure that they're doing the right thing. It's never a bad idea to kind of do a checkup of what you're taking for a lot of the reasons I said at the beginning. I'm going to presume the rest of you are in that bucket? Great. So we're going to go through stuff that will help all of you understand a little bit more, learn a little bit about how Medicare works, okay? So, Medicare is a federal program, okay? And those of you who are already on it are familiar with your Medicare card. Those of you who aren't will be familiar with the Medicare card. This is your insurance card, basically. And you'll notice that down here, it tells you, other than your name and your Medicare number, hospital Part A and medical Part B, and it tells you the start date, the month and year in which you started each. This is important. We'll describe what they are, but they're very different, both how you pay for them, how they work, and what they cover. But what's important about Medicare is, keep in mind, Medicare is not 100%. Medicare is at best an 80% health plan, okay? So that means that, yes, the government's there to help you with a lot of your costs and your needs, but not all of them. And when Medicare was actually written in Congress many years ago, I think during the Kennedy administration, they never intended Medicare to be all-encompassing. It was never going to hit every single healthcare need you were going to have. And most notably, the things that were excluded from the original Medicare legislation are coverage for your eyes, your ears, your teeth, and the drugs you get at the retail pharmacy. Why? Because way back then, these were not big things. The technology wasn't such a big thing. The number of drugs you would get prescribed for you was not a big thing. They were not as expensive as the things we get filled right now at Rite Aid and, well, at Walgreens and CVS and so forth. So big changes have occurred. But if you go online to this Social Security website, and I did say Social Security, when you first enroll in Medicare, that happens through the Social Security Administration, not the Centers for Medicare Services. Two big different agencies in the government. But Social Security, who I'm sure you're all familiar with, the place you go to get money once you decided to collect your Social Security, is also the agency that administers signing up for Medicare. So you go to their website, to actually sign up for your Medicare benefits, way back when you get started with all this. Now, we're gonna go through specifically how you do that, but you can do that. You can check with the Social Security office, and here we go to Norwood over on Route 1. What I can't tell you right now, because it seems to be changing with the administration in Washington, is you read about stories like the number of people working in Social Security is being downsized or doged like other agencies in the government, and that's true. The other thing that's happened is they've rethought how you can prove who you are when you sign up for something with the government. They don't necessarily always believe you. So now they've bickered back and forth with whether you're going to have to do this in person, or is it okay to do it online, is it okay to do it by the phone. Signing up for Medicare gets included in this confusion. So I honestly wish I could tell you, but I can't, because it seems to change constantly. Whether or not Social Security office in Norwood is open, that I do know. It's sometimes difficult to walk in there and have them do anything. They might tell you that we can't have you walk in for an appointment, or they might say, sure, come on and we'll take care of you right now. There's a phone number. You can call Social Security in Norwood. We do have a direct line to them. And sometimes they'll say, we can handle your need on the phone. Others will have you call back for a telephone appointment, or they're going to call you for a telephone appointment, or they'll tell you, come on in. But I got to tell you, it's really up in the air right now what's going on in terms of how to best sign up for Medicare when you first start turning 65. But suffice to say, when you're hitting 65, you're certainly going to want to sign up for Medicare. You can start doing this 3 months before, as we said, but nothing will start until the month that you actually turn 65. And when they do start you for any Medicare services, the first of the month is the only day those things will start. So a lot of what we do when we meet with people in our SHINE meetings, and they're saying, well, I'm going to be retiring, or I'm going to be signing up for some reason or other for Medicare, but I have to figure out, I'm going to be working through the 15th of the month, and when do I have my Medicare start? Medicare is totally inflexible. It's going to be the first of the month. You pick the month. So if it's either your birthday month, or if you're past that, you're retiring, you're leaving job, you're going to be leaving on the 18th of the month, Medicare doesn't care. It's going to start the 1st or the 1st. You have to figure out how your employer insurance is going to cover you up until the last day of a month, because the first day will be when your Medicare is going to start. So that's important. The timeline is important. You can go to the website for Social Security, this link right here. You can create an account in what they call My Social Security, or socialsecurity.gov. Go to that account you've created. You look up where it says enroll in health benefits. They're referring to your Medicare. And that's how you go about the business of initial enrollment in Medicare. Alternatively, there's papers you can fill out and submit. There's calls you can make to Social Security, or you can try and go see them. But if all else fails, you can go onto the Social Security website, make sure you've got an account. We have a one-page instruction sheet we can give you, in fact, that tells you this is how you create your own account. It's secure, it's up in the cloud. That's also the place you're going to go when you do decide you want to start collecting your Social Security money, or you want to see how much they think you've contributed over your life, how much you're going to be paid, all those Social Security things. But in addition, it's getting your Medicare there. And that was group one. That was the people that are just starting, just approaching Medicare. Now there's the other group, those that have been working. They were 65, they're still working. When they signed up for hospitalization, which is Medicare Part A. They declined the Part B, which the government allows them to do. But now they're going to be leaving their employment, and they want to make sure they get Part B as well. Part B is going to be very important. This is for all of your outpatient things like doctors and labs and radiology and physical therapy and all sorts of things that happen. Pretty much everything other than being a patient in the hospital and the drugs at the pharmacy, everything else falls on Part B. So you're going to want to sign up for that, but the government says you can either be covered by Part B, sign up, or you can be covered by your employer's insurance. Just said this group number 2 is leaving their employment, no longer going to be under their employer's insurance. Because of that, they need to sign up for Part B, and then address what they do to fill in the 20% that Medicare doesn't cover. So to do that, there's more paperwork involved. It's not intense, it's not difficult. There's a link you can go to upload your information, your form that you get filled out by you and your employer, and that will start your Part B. Once you have that, then you're going to deal with your supplemental insurance. But I would just suggest if you're approaching that a few months before this time happens, you want to make an appointment to come down and see us, and we'll help you figure out this is what you have to do first, this is what you have to do next, and the timeline should match up in this manner so you don't miss any deadlines, you don't do anything in the wrong order. It's not complicated, but I will say it's confusing. And when I say that, I can tell you that the number of people that we consult with, that we counsel, it's pretty broad. And a lot of people come down, they're very apologetic, and they'll say, I don't know anything about this Medicare, it looks so confusing. And they're not wrong. I mean, everybody says that. Some of the other people that say the same thing, we've got physicians, couples that are both physicians that are retiring, they come down, sit down, and we walk them through the whole process. Just because you've treated patients doesn't mean you know how the insurance works, and that's what they conclude. So don't be concerned that it's too confusing. Nobody should understand this by nature. It just doesn't make any logical sense. So that's how we get those two groups sort of into the system, okay? We're going to talk about now, really, the rest of the time is how does Medicare actually work? What does it do? And through that, how are you all going to make sure that what you're doing now is in your best interest, is the best alignment of plans? We'll go through all of that. Okay, so I've alluded to Part B, I mentioned Part A, I said something about Part D. So there's basically 4 parts to Medicare. Part A is hospital insurance. Now, to be clear, this is not going to the hospital, to the ER, it's not going to the clinic, it's not getting ambulatory surgery, it's not visiting your doctor, whose office is on the lobby level of the hospital. It is in a bed, in a Johnny, upstairs, that's where you are. You're there for overnight at least, multiple days probably. But you might be there for a medical reason, you might be there for surgery, you could be there for trauma, you could be in the hospital for a whole lot of reasons. But Part A only deals with you when you are an inpatient, period, that's it. So what's going to happen is you go, you get admitted, you're upstairs, they're giving you supplies, drugs, and food. All those go into the bill the hospital's going to send to somebody, and in this case they're going to send it to Medicare, and they're going to pay it for you in total. They're going to charge for things like the room and board, they're going to charge for the heating, ventilation, and air conditioning, they're going to charge for the salaries for the nurses, security, the pharmacist, the lab, everybody. So all these things are what we call hospital-owned assets. The hospital owns all these things, and they're entitled to bill for them. They're costs of doing business. And that's exactly what will happen. So let's say you're admitted, you're at Newton Wolseley, the bill comes to 20 grand, they're going to send that bill to Medicare under Medicare Part A, and Medicare's going to pay it. You'll have nothing to do with that. But you will get a bill for a deductible, $1,676, and that lasts you what they call a benefit period. So when you come in, you're admitted, the big bill goes to Medicare, but you get this $1,676. This number may change next year. Medicare changes these numbers based on the budget every year. So that's a bill that becomes your responsibility, or for our purposes here, we're going to refer to that deductible as gap number 1. And there's 3 gaps in Medicare. And the purpose of supplemental insurance is to fill the 3 gaps. Because although $1,676 doesn't sound like a ton of money, that's going to repeat if after 60 days you're back in again, another $1,676. But within that first 60-day window, you're discharged, you can come back in for the same or any reason. They won't send you another deductible. But the moment you go to 61 days, another deductible. So if you get admitted a few times, you could build up a few $1,676. Now all of a sudden, we're talking real money. And that's just the first gap under Medicare. So these gaps can, as I say, add up, and that's what you want to buy insurance to protect yourself from. And they call that Medi-Gap insurance. The 3 gaps, Medi-Gap insurance. Makes sense. The other thing that's a nuance of Part A, which really, I get a lot of calls from people, they just don't understand it. You know, I was admitted to Faulkner for surgery, I saw there was a bill that Faulkner sent to Medicare and they paid it. I got this deductible taken care of. And then a week later, I got a bill from my surgeon. What is it with that? And I got a bill from another person that I don't know the name of this person, but it says Anesthesia Associates. Well, that surgeon, that anesthesiologist, any of these other doctors, they are not hospital-owned assets. They're independent contractors. They're no different than the dermatologist you go to see, or the lab you go to for your blood, or the x-ray you got, or a CAT scan. They are not owned by the hospital, so they're totally entitled to bill you separately, and they will. But they, like all the other doctors and all the other services you might be billed for, are considered outpatient because they weren't part of that inpatient bill. And that happens under Part B. So Part B, or outpatient services, that's going to include anything that's going to happen to you other than being an inpatient and other than the drugs you get at a retail pharmacy. That's how it gets defined. So Part B, therefore, is like the biggest umbrella of services that you could need. And it's not complete. There's 2 gaps under. That rounds out the 3 gaps I mentioned. The 2 gaps under Medicare Part B are a deductible of $257 this year, for the year, and the fact that they only pay 80%. They don't pay 100%. So 20% copay. So you start thinking about doctor's bills and other bills for labs and radiology. If you think you're responsible for 20% of that, number grows pretty quickly if you have some things getting done. And that's certainly something you want to shield yourself from having financial responsibility for. Now the other thing here is Part A, that hospital insurance, is free. There is no premium for this. So even though they're paying that big hospital bill, if you've worked the requisite number of credit hours over your life, you've paid into the Medicare Trust Fund, and it will pay those bills for you, but you won't pay a premium to have that insurance. Part B, different. Part B, you do have a premium. The premium's $185 per month right now. Could be higher if you're a high wage earner, but right now the base would be $185 per month. So what do I get for that? I pay my $185 every month to the government. Maybe I pay it as a bill. Maybe I would deduct it from my Social Security, my preference, whichever I'd rather do. But it's $185 a month. And for that, when I go to the doctors, when I get labs and radiology and all these things done, the government is going to pay 80% of the charge. So, for example, I go to a doctor, let's say the bill's $100. That bill's going to go right over to Medicare. Medicare's going to look and say, yeah, we'll pay $100 for that, but we only pay 80%. So they're going to pay the $80. Now, they're going to let the doctor's office know that here's your 80%, the 20%, you got to get it from somewhere else. So really, that somewhere else is you. You're responsible for those charges. So, all right, now I'm responsible for $20. I get it. But maybe I decided to get an insurance plan that will cover the $20, or that Medigap insurance. Let's just say arbitrarily I bought it from Blue Cross. So here's Blue Cross over here. They're my secondary insurer. So the first bill, $80, gets paid for by Medicare. Doctor's office sends the bill for the 20% or $20 to Blue Cross. They're going to look to see if I've paid my deductible, my $257 deductible yet. Let's say it's the beginning of the year, I haven't paid any deductibles yet, so I'm zero there. They're going to send that bill to me, and I'm going to pay it. So once I pay it, I've now paid 20 of my $257 annual obligation. Let's say a month later, the doctor says I got to go for an MRI. Say it's $1,000. That's fine. That $1,000 charge will go over to Medicare once again. They're going to approve it. They're going to pay 80% or $800. They're going to tell the MRI company, you get the $200 from the Medigap company, so they're going to send that bill to Blue Cross. Blue Cross is going to look and say, well, you paid that $20 towards your $257, but you still haven't got the $257, so they're going to send that $200 bill to me, and I'm going to pay that out of pocket. Now I've paid $220 of my $257 annual obligation. Say a few weeks later I go to another doctor, do the arithmetic. Brings me up to $257. From that point forward, for the rest of the year, no matter what happens to me, no matter what doctors I see, what lab tests I get done, what x-rays, CAT scans, visits to the ER, clinic, ambulatory surgery, whatever I get done, If it isn't something that's making me be a patient in the hospital and isn't a drug I got at CVS, it's falling in this bucket. I'm gonna pay off that $257 the way I just described, and after that, the bills will go 80% paid by Medicare and 20% automatically is going to be paid for by Blue Cross. I'm not going to pay anything more. So as we enter retirement, as we exit employer plans, as we start to go in Medicare, people can commonly get very concerned. They hear stories of people being financially wiped out. You know, fixed budget, I've got my savings, I'm not working, there's not a whole lot more money coming in anymore. What happens if I get devastated with healthcare? Well, you really can't, because if you think about what I just described, your obligation is going to be paying the premiums for that insurance, paying the $185 for the Part B to the government, and then paying the $257 deductible for the year that I'm going to pay. That's it. If I had $1 million worth of healthcare expense, I'm still going to pay the $257 and the premiums. That's what's coming out of my wallet, and the $185 over to the government on a monthly basis for my Part B. So fear not. I mean, you really shouldn't be facing catastrophe financially in most cases for things like, because that's the way the system works. So that's Part B. What we're going to talk about in a minute is what do I do to fill this? Like if I don't want to be responsible for that $1,676, remember gap 1, and if I don't want to be responsible for that $257, gap 2, and I want to make sure somebody's paying the 20%, gap 3, what do I do, what's it cost me, and what are my options to cover that? So we're going to talk about that, because that will become the biggest decision you make as you enter Medicare. Doing this, you have no wiggle room here. The government tells you, you're going to sign up for A, you're going to sign up for B, whether it's when you turn 65 or when you leave your employer, you're going to be doing that. So we're all going to have that, and it's all going to operate as I just explained. The part you have to think about is how do I want to get that insurance to fill in those 3 gaps, because that's where people have preferences, and we'll talk about those, because that will lead you to make a decision on what kind of supplemental type insurance you're going to want to have. Part C. Part C is a way that we fill in those gaps, okay? This is another name for Advantage plans. So any of you that are familiar with the TV ads with like Joe Namath talking about, I got this great plan and they send me this and they give me rides to the doctors and pay for my gym and they give me doctor visits, they give me teeth and everything. He's describing an Advantage plan. This might be right for you, this might not be right for you. But Advantage plans differ from that Medigap plan I described in that both are options to fill those gaps, but they work entirely different. And you want to make sure which one's right for you so you know when you're signing up for the thing that will be most compatible with your lifestyle needs, okay? But Part C plans take your hospital, they take your medical outpatient, they take your requirement to have prescription coverage, they push it all together into one package with one company. They add in some of those things were not included in the original Medicare laws, like hearing, teeth, and vision, and they make a one-stop shop for you, conveniently priced, and it looks very enticing. But there are caveats to it, and we'll outline a few of those in a minute. Okay. So just a real quick reminder of the dollars here and the way these coverages work. Remember, so you're looking at things that, coverage is going to be inpatient, outpatient, home care services, but there's no family plan under Medicare. So heretofore, when you work, you may have had the family plan. Covered you, covered your spouse, covered the kids grew up, they left the home, then it was you and your spouse. When you hit Medicare, there is no more family plan. Everything's individual. So what happens if you have a spouse that has the employer health plan, you've been under this plan, they've now hit retirement, they're going to be leaving, they're exiting their employer plan, they're going to be going on Medicare, but you may not be Medicare eligible yet. You're not going to be on Medicare, not for a while, not till you hit 65 as well. You're going to have to find something else I will tell you something else usually gets pretty expensive because you're looking on the open market for health plans. But there is no family plan left. So although we work our lives usually with health plan, family plans as options, that's not an option under Medicare. Everybody has their own decisions to make about what they do. Here are the out-of-pocket costs we mentioned. The premium for Part B, $185 a month, deducted from your Social Security, or you get billed quarterly. There's no cost for the Part A. One of the things to be aware of, if you have a health savings account, like a high deductible HSA, which a lot of people have with their employers, having more and more of them, you can't sign up for Medicare yet because there's tax implications. Deductibles, remember that $1,676 under Part A, hospitalization. The $257 under Part B, those outpatient, that's the deductible there. The copay is coinsurance 20%, so Medicare is paying 80%, you're paying 20%. And last is something called an IRMA, or income-related Medicare adjustment. What's that mean? Well, Medicare Part B, this $185, is dependent upon your income. And if you file your income tax jointly, it's your combined income. And your income is going to include not just your salaries, but it's going to include dividends, things you got from other sources of income you had during the course of the year. They add all that up, and it reflects itself, as we all know, on the bottom line of your income tax return. That's the number the government takes. And they look at that number, and they compare it to a chart. And if your number is higher, the higher brackets, then 185 escalates very quickly to something much higher than that. I'll show you the chart in a second. But this is what they call an IRMA. So what will happen is you're hitting 65 or you're joining Part B, you sign up, you're expecting a budget of $185 a month will be the cost for that. And then you get a letter from the government saying, oh, your income causes us to put an adjustment. It's not 185, it's a lot higher. This is your new number. That's a monthly number you're going to pay. Now, the trick to this is understanding that when Medicare and Social Security work together to figure out what your income was, they're going to do this based on what your income tax said 2 years in arrears. And think about it. If they're going to tell you what your premium will be in calendar 25, and it's income dependent, you haven't filed your income tax return for 25. We haven't even finished 25 yet. In fact, if they looked at 24, those are still in process. They have to go back to calendar 23, and that's what they do. They look 2 years in arrears, they look at what you submitted on your income tax return, they take that number, they assume nothing has changed in 25, and so what you made is what you'll make. And if that number is at the high end, they're going to charge you that higher number. Well, a lot of the people that we meet with say that, but that's wrong. I retired in 25. My income dropped. I retired. Let me say it again. I retired in 25. My income dropped. What are some of the other things people don't even think about? Inheritance, hit the lottery, sold a house, robbed a bank. I mean, whatever you could do to have gotten more money in 23, if you put that in your income tax return, the government only knows a number. They pull the number, and what they do is they look at this chart. And so if you were married, filed jointly, and your income for that calendar 23 was from 212 up to 266,000, you're going to pay not 185, you're going to go up to 259. And on top of that, you're going to pay a surcharge on the prescription premium that you have. If your income's here, and I will tell you that we've had people come in that do hit these higher numbers, and they're like, oh my God, I mean here, and I know I'm making a lot of money, I get that, at least 2 years ago, but I did that because I sold a house. I don't have more houses to sell. So we understand there's an appeal process. Or they say, yeah, but in 23 I was at the pinnacle of my earning career, and so wasn't my spouse. And so collectively we made a lot of money, but we both just retired, and all that money is not coming in calendar 25. The government has to understand that, and they give you an appeal process to explain it to them. So we can help you to go through this if you fall into that bucket. But whether you're single or whether you're filed joint and married, they've got their numbers that will lend themselves to an elevated Part B premium and an additional surcharge on Part D. So no need to panic, because there are things you can do about this. But it's important to be aware of it, because ultimately, if you didn't know that, and you paid the higher number, you have overpaid, and you've overpaid significantly. Well, 2 years out, when the government pulls your income tax return from calendar 25, and they see what they charged you, they're gonna say, oh my gosh, my golly, we charged them too much. We'll give them a credit, and they will. You'll get your money back, you will be whole. But thank you very much, you just floated an interest-free loan to the government for 2 years, and you probably would rather have that money in your pocket than in the government's pocket. So it's important to know this appeal process is available to you if you want to do it. So just to kind of graphically show what we talked about here. Remember those gaps, and we're talking now about filling those gaps, how we fill those gaps. Well, this is original Medicare. You have your A, you have your B, you bought that Medigap plan. Remember we talked about Blue Cross over here. That was that Medigap plan. You paid that premium too. And then you got prescription coverage. That gives you complete coverage. And then to this, people will add secondary coverages, like for their teeth sometimes, or for their eyes, ears, and so forth. They can buy little riders that go on to the Medigap plan and allow them to round out their coverage. Or they go with the Advantage plan, Part C, that we looked at a second ago, where they took hospitalization coverage, other outpatient coverage, drug coverage, threw in those other benefits of eyes, ears, and teeth, and they gave you an Advantage plan instead. Now these plans, and this is where it starts to get different, these plans, anybody that takes Medicare, any provider, any hospital, lab, radiology, specialist, physician, physical therapist, anybody that can bill Medicare can take that Medigap plan here or another state, wherever. So this is important when people come forward and they say, when I get my rounding out my coverage, I got like these 4 doctors I've gone to for the last 8 years. I really love them. I don't want to leave them. Well, okay, that's probably going to be this column of filling the gap you're going to want, because it's total flexibility. Any providers accepting Medicare will have to accept these plans. On the other hand, these Advantage plans, what they do, they run like HMOs and PPOs. And those of you that are familiar, this is very typical of an employer plan, where you'll hear people really ticked off because the doctor they want isn't in the network. And that becomes like the #1 complaint people have is, I wanted to go to my doctor, but my doctor's not in the network. And the networks can change. I mean, they can be in the network this and out next quarter or next year. So, you know, that's a relative term, in or out of a network. But know that these plans have networks. Why do they have networks? Well, remember this, I told you that 80% of the cost is borne by Medicare, right? What do we know when you read the paper or you listen to David Muir at night? We know that Congress is concerned that we're going to run out of funds in the Medicare Trust Fund, just like Social Security. And from month to month, one person will say, well, it's going to be 2030. One says it's 2050. You know, all of these different numbers. But suffice to say, everybody agrees that we're going to run out of money. And in healthcare, what we've got is an aging population, sicker population, and the cost of technology for people is going up and up and up. All those things combined means that the money in the Medicare Trust Fund is draining faster and faster and faster. And so the Congress asked these insurance companies, like the Blue Crosses, the Tufts, the Harvard Pilgrims, and others that offer those Medigap plans, they asked them a number of years ago, what can we do to arrest the rate at which this money is coming out of the trust fund? And they said, they offered up something else. They said, well, we can make an alternative to this method here, and we can privatize it by putting Advantage plans of Part C in, if you guys approve these laws, Mr. Congressman. And what we'll do, it'll work like this. Instead of you being responsible for 80% of the cost, you just write us a check on behalf of that person for the year, $12,000 per person, let's say. That should cover it for the year. And if they have higher, more intense diagnosis, the number will be greater than that, but let's say 12 grand. And so if the person opts to sign up here as opposed to here, then that insurance company will get a check for 12 grand from the government to cover the healthcare needs. That's whether you're well or you're sick. And the insurance company agrees that they're going to take care of you, and if it costs them less than 12 grand, they get to keep the money. If it costs them more than 12 grand, they're going to pay for it. They're going to eat the cost. So these insurance companies view this as the potential for making more profit than they did over here. Here they're just paying the 20%. It was already decided. There's no margin here. Here, if they can negotiate the costs for your health care, the doctor fees, the lab fees, the radiology fees, physical therapy fees, the fees for being in the hospital for surgery, if they can negotiate with providers to get lower costs, that helps them capitalize on getting some margin on that 12 grand that they can keep. They want to do this. So part of the rules here was the government said, it's okay for you insurance companies, when you create these plans, you can go negotiate and create rules. So what do the insurance companies do? Well, they negotiate with all the internal medicine practices at Beth Israel Lahey. And they find the practices that give them the lowest rates for certain procedures. And now when you sign up for their plan, that plan, they're going to direct you to go to that medical group because they're getting the best price for it. When you need heart surgery, if St. Elizabeth's gave them the best price for doing heart surgery, then every time a person that has their insurance plan wants heart surgery, they're going to tell you, you're going to St. Elizabeth's because we have the best rate there. Hopefully that means the quality is there too, but honestly, they get the best rate there. So all of these services have been negotiated. And what did I just describe? The beginning of networks. That's where the networks come from. That's why they are. They're not going away. If you're somebody that wants total latitude to go to whatever doctor you want to, you don't want to be in an Advantage plan. On the other hand, if you're somebody that doesn't go to a doctor very often, you got a primary care doctor, just retired, can't remember the new guy's name, who cares? You go, you have one prescription, you don't get a lot of labs done in the course of the year, you don't get a lot of health care. This may be ideal for you because the premiums are lower than these and you're just going to pay for services as you need them. So you pay as you go with a low premium. If you don't go very much, that'll be the most economical way to have your health care coverage. If you get older and all of a sudden you get sicker and you start needing more care and they start throwing a lot of specialists out there that you need to go to at certain hospitals, if those networks don't accommodate your need, that will be the source of your agita, guarantee it. And so what you're going to do is wait till open enrollment, figure out what you should best be in, maybe changing the Advantage plan for different networks or going to Medigap where there are no networks. That's the move you would want to make come that point in time if that becomes bothersome to you. The problem here is 50% of Medicare beneficiaries are here and 50% of all Medicare beneficiaries are here. So I can't even tell you there's some best way to do it. The best way is to figure out what you need and what makes you feel better at night with having your health care coverage, and then going down the path of picking the best insurance plan. But first decide whether you want a Medigap or you want Advantage, and that's something that Bob and I help people with all the time, so you can make sure you're in the right bucket before you drop down and pick out what plan it's going to be. So I'm just going to spend a minute now talking about how those Medigap plans work exactly. Remember there were three gaps we talked about. 20% coinsurance, the Part A deductible of $1,676, and the Part B annual deductible of $257. There's three levels of Medigap coverage, and this is that column on the left with total freedom. Any providers that take Medicare would take these. The least intensive and least expensive level of coverage is what they call core. So you could buy Blue Cross Core, you could buy Tufts Core, you could buy Aetna Core or United Core, whatever, but they all have a core level of coverage. And that means that everything Medicare says it's supposed to cover, they're going to. But they're going to pay the 20%, they're never going to pay the deductible Part A, they're never going to pay the $257. That's out of your pocket. So out of three gaps, one gap they're covering, but that really is the biggest gap when you get down to it. So that's important, they get it, but you're going to be signing up to pay these if you're hospitalized and this $257 deductible. You could opt to get the next level up, a little more expensive, a little more coverage. Specifically, This is going to pay for the Part A deductible. If you're in the hospital, there's your difference right there. Incrementally, the difference in premiums over the course of 12 months is about $900. Sounds like a lot of money. But if you're somebody that's been admitted or think you might be admitted because the doctor said, you know, look, you may have to be in the hospital during this course of this year. This may be the better deal. Pay the $900 more in premiums because you're avoiding at least one of these $1,676 deductibles if you're admitted, because the insurance company is paying it for you. Neither one thus far is going to pay the Part B deductible, so you're still on the hook for the $257. And then the most expensive and the most comprehensive is what they call Supplement 1. Yes, yes, yes. They cover everything, okay? But the premium incrementally here, because the only difference is they're paying $257 on your behalf, is about $400, $500 a year. So I think about it, okay, I could buy that, but why do I want to spend $400 or $500 and all they're doing for me is paying $257 on my behalf? You know, I'll pay the $257, I'll pocket the difference. I don't need to pay them, the insurance company, to do that. But you do have the 3 levels of coverage. I mean, these are your options. Some of the other things that we get into are whether skilled nursing is covered after the 21 days and foreign travel, where these plans will cover you if you're traveling out of the country. But even then, it's important to check with the insurance company and the country you're going to see what they really are going to need you to do. Those are the 3 levels of coverage. These are the companies that sell the plans. The plans are identical. There's no difference. If Medicare said they pay 80%, these plans are obligated to pay the 20%. So that doesn't change. The services they cover, once again, Medicare makes the first decision, and then the Medigap plan has to cover. These are the companies in Massachusetts this calendar year. This is the monthly premium for each of those plans. Yellow indicates least expensive in the column. Oftentimes when people see this chart, if this is the type of insurance they've decided on, they look at the chart, this answers the question that the least expensive company for me to buy that from is Blue Cross of Massachusetts. It is what it is. I can't really find any reason to tell you why you might want to buy 152 and get it from Tufts, or 164 and get it from United AARP, or any of these other companies. 129 is the least expensive. So once again, when we meet with people, if they say, I'm going to go with the Medigap plan, and we look at this chart, the big question is, do you want or not want to have the Part A deductible covered? Because in terms of picking the company, don't get confused. This is straightforward. The least expensive company is Blue Cross, unless you don't like Blue Cross. If you don't, then pick something else. But the best value is right there or right there. And that's helpful to people. So now they know what they're supposed to sign up for. And at that point, you just call the company and enroll what you want. So that's how the Medigap works, the left column of that chart. Now let's talk about the right column, the Advantage plans. How do they work? Everything that I said to you about that Part B 257, about the hospital 1676, about the 80-20, those gaps, those are erased. Those are replaced when you go to an Advantage plan, because remember, the government wrote a check on your behalf to that insurance company to take care of you. Now it's that insurance company that makes the rules for what happens while you're in their plan, both who you can go to and how they pay and what prior authorizations and hoops you may have to go through. So there's a lot more restrictive things. So this is an example of 2 plans from Blue Cross. And I'll tell you, these are 2023. I haven't updated the costs because the process is the same. It's just the dollars are different. So here's one they call Blue Saver RX, and you'll see it's a PPO, Preferred Provider Organization. And this differs from an HMO, which are also available. But as many of you are probably familiar, an HMO, Health Maintenance Organization, is a very tight window of providers you can go to. A PPO says, here's our tight window, you'll pay less money than if you go to others outside, but we are a PPO, preferred provider. We'd like you to go here, but if you go outside of the network, you can, but you're going to pay more. And it depends what you're going to pay with who you're going to see. So, for example, the monthly premium for this plan is 0. How can you beat it? We saw 129 a minute ago. It's 0. That's cool. or 75, which is now 87. And then every time you go for services, this is what you're going to pay. So when you go to your primary care doctor, if it's an in-network, you pay $0 for the visit. If your primary care doctor is out-of-network, you'll pay $25. You paid a little for the premium here comparatively, so you're going to get a little bit of a discount, and you do. You'll see it consistently, slight discount on many of these charges. Some of these charges, when you go out-of-network, you're not talking about a fixed fee. You're talking about a percentage of whatever the cost is. That can be wildly expensive. So you really want to make sure when you're getting these diagnostic tests, lab services, outpatient radiology, etc., these things that the provider they're sending you to is in the network. Many times people come in and say, I just got this crazy bill from Shields Radiology at the Westgate Mall for this procedure I had done. Well, they weren't in your network. They're going to be billed at 45% of the cost of that procedure. If that procedure was $1,000, you're getting a bill for $450. So just got to be aware of this chart of accounts. Now, what happens if you're hospitalized? Remember, I told you that 16 cents, that's gone. It doesn't work that way. Instead, it's replaced with, if you're an inpatient at a hospital that's in network, you're going to pay $390 per day for days 1 to 5. If it's out of network, you're going to pay $440 per day 1 to 5. If you had this plan where you paid a little bit, here's your discount, $390 drops to $325, and $440 drops to $350. But it's money. It's real money. After you hit the 5 days, then you're set because your insurance is not going to be billing you anymore. But that can add up. So the takeaway from this is, even though this is 0, and even though this is 75 or 87, which are a lot lower than the premiums you saw on the previous chart, you pay as you go. So the more you go, the more you pay. You could have a very low premium, but if you're somebody that has a lot of doctors and you go for a lot of procedures, that number is going to keep ticking up. And it isn't going to stop until you hit the maximum they put in that plan, and that may be thousands of dollars. It will be thousands of dollars. So you could spend a lot of money if you're going to a lot of procedures. So different than the thing I told you a second ago about you don't go to a lot of docs, you got the one primary care doctor, et cetera, et cetera, et cetera. That might be ideal for somebody to have a system like this because they're not paying a lot of charges. But somebody that's got a number of doctors, gets a lot of work done, you just don't want to be there because it's going to add up very quickly, and you'd be better off paying a higher premium and having all the services included in under that with your deductible. Does that all make sense? This is really critical. This is probably the most important thing because it causes the most important problems for people to know which bucket you should be in. So just to review them, here's that original method, here's the Advantage method, higher monthly premiums but no copays, lower premiums but there are copays, freedom to choose all providers, generally restricted to networks. So your doc has to recommend or write a referral for you to go see the next doctor. No referrals necessary, referrals for specialists. Routine services are not covered, vision, hearing, because original Medicare never included those. You would probably include these other services. Covered anywhere in and out of the US, only emergency service is going to be provided outside of your network area, okay? Otherwise, you're pretty much going to be dealing with an out-of-network situation. So once again, one of the other characteristics we ask people when they're deciding, do you have a lot of kids? Well, I've got 2 kids. Where do they live? Philadelphia and Dallas. You visit them. Sure, grandkids are there. You can get sick while you're visiting. The network is not going to address your needs, probably, when you're out of the area. So maybe you're better off with a Medigap plan. Not always, but maybe. Other people will come in and tell us, indeed, they're planning to relocate, and they're going to be out of the area for more than 6 months. Well, the Advantage plan won't let you be in there anyway. If you're going to be greater than 6 months out of the network area, you've got to go with the Medigap. So this will cover you wherever you're at. This is not necessarily going to happen. Many times people will start here, young, healthy, older, sicker. They migrate over here during open enrollment. That's perfectly okay. In fact, that's what we're seeing in the statistics nationally right now. Medigap plans, you saw the list a minute ago. Advantage, this is not a complete list, but you can see crossover. Fallon, United, Tufts. We add some new players. When you're looking at Advantage plan, Mass General Brigham Health, they have their own insurance plans. They're great for the local area, and you would expect that a lot of the providers in this Boston area are going to be in the Mass General Brigham plan because it's such a common provider. And you wouldn't be wrong, they probably wouldn't, but you don't know for sure. So when someone says, I think I'm going with an Advantage plan, we provide you with a roster with some phone numbers of each of those companies. And we advise you to make a list of your providers, name, address, etc. Call the company, go through the list, make sure that your providers are included in their network. If they tell you yes, golden. But then you probably want to check with the doctor's office as well. I was told that you take this Blue Cross Saver Blue plan. Is that true? Give them the number. It's on the roster we give you, because there's so many flavors that for doctor's office to say, sure, we take Tufts. Yeah, but there's Tufts. It's not one Tufts. Tell them the plan you're talking about and make sure that that's the plan that you're interested in when you check, so that you know you're signing up for what you're signing up. Know what you're signing up for. Last thing we're going to just talk about for a few minutes is medications. So for a lot of people, the bigger issue is their meds. So you've heard me say the government wants you to have prescription coverage. It's not okay to say I don't need it. Doesn't matter whether you need it or you don't need it, you have to have it, it's the rules. So you should sign up for a prescription plan. In the Commonwealth, in calendar 25, we've got 14 different plans. Here's some of the companies that offer them. Aetna, which is actually CVS Health, has one. They used to have 3 different plans. Blue Cross, they have 2 plans. Cigna, 3, Humana 3, and WellCare 3. You gotta think, like, wow, how can one company have 3 prescription plans? How can they make it this different? Well, they can. One of the plans may have a low premium, one may have a high premium, one may have no deductible, one may have a high deductible. The government allows them to have a deductible of up to $590 for meds for the year. So there's a lot of nuances to each of these plans, and they are different. One plan might take the thousands of meds that are out there, and I'll assign them tier 1, 2, 3, 4, whatever, and it may be different than the tier assignments for one of their other plans. And that tier has everything to do with what your copay is going to be and where your deductible's at. One plan might have preferred pharmacies exclude Walgreens, but include CVS and other pharmacies. So these nuances that are associated with each of these plans, they're all kept in a database in the cloud up above on high that's called Medicare.gov. That's like what I mentioned with socialsecurity.gov, but this is Medicare's website, their official website. And just like you can create an account for yourself at socialsecurity.gov, you can create an account, or we can do it for you, at Medicare.gov. Why is that important? Because there's a lot of math involved here. Bob and I are both retired pharmacists. We would never dare to do the arithmetic involved with comparing 14 different prescription plans if you've got several meds. It's just too darn confusing. But the tool does this for us. It's wonderful. So what happens is we take your account, you've set up, we've set up, we make sure that your med list is correct and accurate and current. The tool, the government's tool, will take that information, it will look at each of the 14 plans. It will pull down the cost for each of the meds, the tier for each of the meds you're on. It'll look at deductibles, copays, it'll look at, you said Walgreens is your preferred pharmacy, so where's Walgreens preferred versus out of network? It'll look at all these things. It'll do the math. It'll drop down a report that tells us the cost for plan A would be $260 for the year. The next plan, plan 2, is $3,464. And I'm telling you, the differences can be this sizable, where the same meds can cost thousands of dollars. Only change you made was the prescription plan you chose, period. That's it. So when we look at the premiums, the deductibles, the tiers, everything else, all factored together, tells us what the bottom line would be with each of these 14 plans. We go through it, we pick out that which is the least expensive. We can suggest that one to you, and if you do want to do that one, you can actually enroll online. It's a real quick process to do that, and they'll send you a confirmation that you've been enrolled, and then the company will follow up by sending you all sorts of information in the card that you're going to give to the pharmacy. And from that point forward, the pharmacist loads into their computer, this is the plan you're on, and whatever meds you get from there forward, they're going to be using that prescription plan's pricing to charge you whatever it is. And this actually works pretty well. Now, this whole process is the thing to keep in mind if you've gone with a Medigap plan where you needed a prescription plan. The Advantage, it includes it already. But the Medigap, to get that separate standalone prescription plan, this is the one thing that we urge people to talk with us every year during open enrollment. Just because the prescription plan you have this year worked like the best, and we told you it was the best value, does not mean it's the best value next year. Everything changes. The tiers change, the co-pays change, preferred pharmacies change, deductibles change, everything changes. And so because of that, we might suggest to you that this is not going to be your best plan next year. This other one would be. And if you want us to, we'll change you and we'll send you back the confirmation sheet. So you don't even have to do that. All you need to do is stop down at the Senior Center front desk, come open enrollment, pick up a form that we have. You'll fill in your meds that you're taking today, current list, and your Medicare number, et cetera, and your address and all that. You leave that behind. We'll call up your account on the computer. We'll go into the cloud. We'll make sure it's correct. Run the analysis, make the decision, give you a recommendation. It's either going to be stay the course, the plan you're on will be your best value again in 2026, or don't stay the course. We suggest this other plan. Look at the report we're sending you electronically through email. If you want us, just reply back, say, yeah, go change me, please, and we'll take care of the paperwork for you, and you'll be converted over, and that'll take care of it. So a lot of people get very concerned, as I say, about prescriptions, and with good reason. I mean, this can be very expensive. Now, last year, you could be spending up to $8,000 out of pocket. That was the maximum cap on out-of-pocket medication expense in '24. The laws changed, and in '25, it's now $2,000. There was also something called the donut hole, or the gap, which people kind of have heard that name or had to live with. And that's when things went really crazy, because the price for a prescription changes if you're in the deductible phase, the initial coverage, the gap, or the catastrophic phase. People will call all the time saying, why is it the script I got filled last month cost me $140? Now they're telling me it's $40. I mean, did they charge me wrong, or are they charging me wrong? I mean, what's going on? No, that's all in the plan. That's the way it's laid out. Because of the math involved, each one of these phases has a different pricing structure at any given med. We've only got 3 now, so you're going to pay a price during the deductible phase if you've got a deductible, and that's somewhere around the list price of the med. So you could walk in the door of the pharmacy and they say, you're getting your Eliquis filled this month, and that's going to be $590. Well, that means you're paying off the $590 deductible. Once you've paid off the $590, the cost for your next prescription refill might drop down to under $100, which seems crazy, but it isn't. It really is the way the contracts have been set up. That is the way it works. But fear not, today, as of 2025, that expensive prescription is going to stop when you hit $2,000. You won't pay anything beyond that for any prescriptions. So you want to make sure you're in the best plan, updated open enrollment, that which I just suggested. Your annual out-of-pocket won't exceed $2,000, so that's good. I mean, if you're on these expensive meds, that can be a whole lot different than the $6,000 you had to contend with last year. And you can also do something called spread payment. So if you're somebody that is going to spend the $2,000, and we can project it's going to be $2,000, you can, if you'd opt to, pay the higher dollars up front. Remember that $590 to pay off your deductible in the first month, and then lower amounts. Or if you'd rather, there's a way for us to project if you spread those payments more evenly over the course of the year, you could do that. So for cash flow, it may be more comfortable. for somebody to do that. And we'll recommend that if we see somebody's gonna hit the 2,000, or you can even just ask, what about the companies are supposed to tell you too, you might be eligible for this. So that pretty much kind of went over all of Medicare. What do you do to get into it? What do you do if you're partially into it to finish it off with your Part B? What do you do when you're leaving employment or spouse is leaving? And then we talked a little about what A and B is, and then filling those gaps, which is so important to know what the best value is for you in terms of the plans that you're getting. So I'm just gonna pause there and see any questions or anything from anybody. And I wanna make sure that we at least hit some of the things you wanted to learn about today. So are there any questions? Sure.
Two things. A
Sure.
comment first of all.
Yeah.
You did the Part D analysis for us 2 years in a row.
Oh,
We changed 2 years in a row.
sure.
You saved me a lot of money.
Good, good,
So I would highly recommend
good. Glad to hear that.
you use them for that.
Good.
The other thing is on the IRMA adjustment.
Yeah.
That's automatic. It's been a lag 2 years.
Mhm.
Okay.
Yeah, so every year to set your Part B premium, you assume you're gonna pay the base, the 185. But it doesn't change the fact that Medicare and Social Security and IRS are gonna take this tape of what your income from tax return was 2 years ago, run it through the mill, and those people that have an income that hits the IRMA will kick out an additional letter, and they will follow up and let you know that, forget what we said on the first letter, you're really gonna pay this number. And that's the thing that should prompt you to take action. If you see that, you can Google, appeal IRMA. You can call us, we'll give you the package to do. But if you fall into that bucket, you could do that. Many people, it takes 2 years to wash it out. Personal experience took 2 years to wash it out. And my wife and I both started Medicare at the same time. So for her and myself, I had to appeal it 2 years for both of us. And it worked. I've never heard anybody get turned down when they did the appeal, so it's gotta be 99% that it works. But, and as I said, you're not gonna never be made whole. You will be made whole, but you probably had better use for your money that you overpaid in those couple of years than giving it to the government for free. Okay?
Are you better off filing separately for the taxes?
Yeah, that's a good question. I don't have an answer for that. You may check with the accountant, and if you've got a tax guy that does your taxes, because that's certainly an option to file separately. But at the bottom line, I don't know that it makes any difference at all. I think it probably does. There are other, for example, support programs. There's something called Medicare Savings Program, for example. And one of the Shine counselors that Bob and I work with, now I don't know if she's done this or not, but she decided that she was better off filing separately from her husband because she would qualify for her income being low enough, she would then get this support, but together they wouldn't. So there may be that, but just straight out, what I showed here, would it make a difference? Yeah, maybe, maybe not, because that IRMA, filing jointly means you're both gonna be tasked with the IRMA, and you're both gonna have to appeal it. You'll both be eligible for it, but if one was really contributing the greatest degree of the income, you'd have to go back and say, all right, so now we're filing singly, there was a different chart of numbers there, what's that gonna be, and how's that work out compared to the person at the base of 185? I just don't know if it would make a difference.
How does that work if you're selling, if you have like joint assets? Like say you have an investment account, you're retired and you have to pull money out of the investment account. If it's a joint account, I don't know how they would break that down.
So if it was a tax deferred account, which is gonna be different
No,
from.
it's like a taxable brokerage account and you sell assets and you create capital gains.
Yeah.
It's a joint account.
Yeah,
Would
That's-
they just, that gets, I think,
well, if
could it
you,
be 50-50?
if you're filing your joint return,
Yeah,
you're getting whatever
Right.
that's getting to that bottom line.
right.
That'll get applied to here, and then it'll apply to both of you.
But if you file singly and you
Oh.
have joint accounts,
Yeah,
can you
I-
actually break that out? I don't know if you can.
Yeah,
I guess you get 50% of whatever you take out. I don't know.
that's why I said talk to the tax expert. 'cause
Your
I'm really
accountant will
sure.
charge you more to figure that out.
I kinda sense that if that really was a thing, we'd hear a lot of people doing that thing.
Yeah.
But I haven't ever, but I do hear the question come up, and it is interesting, but I never did the math.
How do we make an appointment with you?
So what you do is you just check downstairs, they'll just send me a referral, and then I'll follow right back up with you, usually within a day or two, and if I can't get you on phone or email, I'll just kind of screen what your need is. A lot of this is, we get busy, certainly during open enrollment, so we tend not to do a lot of individual meetings then. But if it's like right now, I mean, in summer it's wide open, we just have you come in and go over it. I will tell you that one of the things we try not to do is people, and I have no problem with someone being an eager beaver. You know, they know, well, I'm gonna turn 65 next year. So I wanna find out what I'm supposed to do now, and I get that. Guarantee though, whatever we go through now, no one's gonna remember in a year, and we're gonna have to do another meeting. So I try to hold people when they're a little closer to the real date when things are gonna happen, but not too close, because anything can go wrong.
Sure.
All right, there's a lot of snafus that occur with this stuff. We had a friend of mine that he was up to the 11th hour trying to get his paperwork done to submit for his Part B, and the problem was he worked for a very large pharmaceutical company that had outsourced their human resources function, and he was chasing all over the place trying to get someone to fill out the form for him, and he couldn't get that done until the 11th hour. So stuff happens. Any other questions?
I do.
Sure.
I have a ton.
Oh. Make an appointment.
That's what I think I need to
Sure,
do.
yeah.
Because I take a lot of medicines, so that's a big concern for me.
Yeah.
So I think I need to do that to see if I'm on the same page.
Are you on Medicare now? Or
No, I'm not. I actually will turn 65 in August.
Oh, absolutely
So
want
I'm
to
trying
talk
to
now.
get, so I'm trying to get ahead of what I need to do.
Okay.
I do have, my supplement is with my work, so when I do retire, that would be my supplement.
Are you like?
I work with the town.
Okay, a
with the town.
GIC?
A
A GIC plan? Government?
Yeah, the town.
Town, Walpole? or
No,
something
it's
like-
actually in Needham.
Needham, okay.
Needham,
Yeah.
so under that, where I've worked there, I can pick up the supplement with them.
So, yeah.
So my other question is,
Yeah.
right now I'm on Harvard Pilgrim Health.
Uh-huh.
It sounds like the Blue Cross is probably a better, I'm wondering if I should switch over.
I would first check with human resources people in Needham.
Yep,
Have them provide you what your options will be. So you're gonna retire from the Needham, but you're gonna be under the Needham retiree health plan.
correct,
Ask them for the plans that you have as options.
yep,
They probably will, and this is where it gets a little dicey. They probably will have a hybrid available to kind of what we were describing in the Medigap and the Advantage. They negotiate the best for this, the best for that to create some options for you. They won't be exactly this, they won't be exactly that. And honestly, the best source of understanding what their plans are, including the medication part, is them.
okay,
We're told when we're trained, don't delve into the details of these things because we're not trained or expert in the nuances of Needham or Walpole or Canton or Massachusetts or the feds or Polaroid. All these companies and public entities will sometimes negotiate the retirement plans for their employees, part of your package. And it should be a good part of your package, but I don't know the details, so I don't know how to navigate the best thing. Certainly the A-B thing, they're gonna tell you sign up for A or B. They're gonna just tell you that, but check to make sure. Then get the package of what they offer. You can make an appointment, we can do that, sit down and look at it together. Just know that all I know is what I'm reading along with you,
right,
and I can't tell you the tricks of the trade with any one of them. Needham should be able to do that.
okay,
Okay?
Yeah.
Is that help? And especially with meds. They may have a plan that, they may lay out these three options and say, yeah, the people that have intense meds, this really is the one that turns out to be most comprehensive for them. Now, it might be Harvard, and they may not have a Blue Cross, but pretty suffice to say that whatever they would offer for Harvard or Blue Cross would not look exactly like what we're talking about that I could sign up for,
Right.
not being under that retirement plan. And you would want to make sure that as a retiree, they've done something to give you something that's beneficial. That doesn't always work that way. We had a woman that had worked her career with one of the large airlines. She had visions of her retirement plan when she was making all those flights. And then she came in here with the booklet they had from her airline and we went through it, and I just could not figure out why this was any better than anything I could sign up for, having never worked on that airline before. Bottom line was, she didn't stay with that plan. She went on to something outside, like a Blue Cross plan, which was better value, better coverage for her than the airline had negotiated as a retirement plan. Now she's asking me questions like, you mean I just spent my career working for them and my retirement plan is a joke? So, I don't want to go there, but
Right.
I can't tell you why it's a whole lot better. The other thing to be aware of is when you have a retirement plan offering, and then if you decide you're going to leave it and go outside of it, you can't get back into it.
Right.
Other thing is, some of these companies and government entities will also help you with other non-visible things, like they'll pay part of that 185 Part B premium, part of your package, or they will give you an allowance of, like, they're going to cover like $1,000 worth of health care for you, and that has to be administered by a company called, like, Aon is one of the companies that do this. So they tell you to talk to Aon, but do not do anything on your own. Whatever you decide to do, have Aon do it for you, because if you do it on your own, you just gave up this $1,000 we were sending to Aon to help cover your expenses, part of your retirement plan. So it's really important to know what is part of that package, so you don't lose out on part of the benefit for it, or take something that's not maximum beneficial to you. So do your homework and need them first.
So I am not gonna retire next year.
Mhm.
I still have to sign up for Medicare.
So when you turn 65, what we usually recommend is sign up for Part A,
Yeah,
no premium, hospitalization, works in concert with your employer plan. It's benign,
okay.
okay, but it's gonna
It's
get you
just
your
to sign
Medicare.
up, but then when I retire, I can sign up for something else?
So when you go to retire, now in your case, this
Yeah.
is what's different. If you're retiring, but you're staying under your employer's plan, you'll probably sign up for Part B.
Right,
And then that employer plan, your retirement benefit, will be your supplement. As you said at the very beginning, it will become a supplement. So that's what your path would be, okay? So they can explain to you best what that coverage is going to give you, what it's going to cost you, and, you know, all that sort of stuff. People that don't have that retiree plan, okay, when I turned 65, just a few years ago, I signed up for the A, signed up for B, because I was no longer under my employer plan, so I had a B, it's B or employer, so I
Yeah.
signed up for B, and then signed up for the supplement that went along with it. But I was not predetermined, it was whatever I found to be Medigap or Advantage, and then what company and what plan. But that's different than your situation, because your retirement plan is sort of providing you something to kind of lead into. And if there's any nuances to that, the town of Needham's gonna be able to tell you what those would be.
okay,
They really will be a good resource for you.
okay.
Yeah, but certainly you can make an appointment with us and we'll look over it. And if you got a year till you retire, then it's not really mission critical to sign up for Medicare. You could hold that off, but it's just easy to do it. Know you're all set. Know you're in the system. Know you got your Medicare number. It's Part A. It's benign.
So that's what I thought you had to do, but you had to sign up whether you're working or not. for
You
that
don't
extra
have to
year,
sign-
just so that you're,
As long as you, the B is the important part. Part A, no premium or anything, they don't, it's not critical that you sign up when you're 65.
right,
But if you're not under an employer's plan or a spouse's plan, then
and that's.
yes,
what
you're
they
gonna
want you
be,
to-
and B is
and
what they
that's
really is
penalize
gonna.
you, if you're not
Yeah.
under somebody else's plan.
Yeah, or not working under an employer
Okay.
plan. Part A's got no premium, you can't penalize somebody that's already paying zero, other than twice zero. Part B, you are paying 185, and they can tack a penalty on it and make it 257 or something,
Right,
But, so the government's lax when it comes to Part A. They advise you to do it, but they don't require you to do it. There's no penalty if you didn't do it right away.
okay,
But there is if you don't do the B on time.
okay.
So if you're opting out, declining, because you're under a spouse or an employer's plan, that's fine.
Yeah.
The moment you're no longer gonna be shielded by that, make sure you're on your Part B. And then the supplemental questions come up. or in your case, it's your retiree supplement that will come up.
Okay,
Okay?
thank you.
Now that I made it even more confusing. Any other questions? No? Well, thanks all very much. Really appreciate it. We're right on time. I know we got a lot of information unpacked, but as I said at the very beginning, Medicare is anything but straightforward. It's a typical government program. And every time they say they're gonna make it easier, you better be worried because that's gonna make it worse. But it's just a plan that's been around. Thank God we got it, but yeah, but look, there's shortcomings to anything like that, so. All right, thanks.